Hi guys, welcome back to Codemaster Coach, your medical coding tutor. Today I'm going to continue my series on UHDDS, which are the Uniform Hospital Discharge Data Set. These are the guidelines, the rules of how we line up our codes. My students always ask me, how do I know what to code? Well, these UHDDS guidelines let us know what's required, what's uniform in all facilities to report. In my last video, I talked about the principal diagnoses, which is that first listed diagnoses, that the meat of your visit, the weight. I said you buy one pair of shoes, you get the other half price. Well, that first diagnosis, your principal diagnoses, determines the weight, the charge for that admission. And then the additional diagnoses, which are the ones we're going to talk about today, can have a bearing, can bring more reimbursement, can add more charges to that patient's stay. Therefore, we need to know what additional diagnoses should we be capturing. So again, in today's video, we're going to be talking about other reportable diagnoses. So what are the other reportable diagnoses that we can also add to a patient encounter? It's those conditions that coexist at the time of admission or develop subsequently. You know, a patient can come in the hospital for one thing, but oops, they also have high blood pressure and that has to be monitored, or they have diabetes, or they have other conditions that also have to be taken in consideration along with that principal diagnosis. Well, if your facility has to monitor or has to run lab tests or has to still take care of, make sure that patient gets their daily blood pressure medications, or the physician has to prescribe additional medicines or treatment, then that's an additional diagnosis that we should be capturing. So, diagnoses that have no impact on patient care during the hospital stay are not reported, even if they are present during that admission. And we're going to talk about some examples further down the line here. And then also, physicians are good at, in their diagnoses, listing conditions that occurred on a previous admission. It has no bearing on this current admission, but they'll tell you that. This patient also had the tubes tied 2 months ago. Well, today they might be in for a heart condition. That has nothing to do with this admission, so do we code it? Do we not? So that's where these rules for today are going to come into play. Okay, so when I say diagnoses that affect the current episode of the hospital care, these diagnoses must require clinical evaluation, some type of testing, some type of labs, some type of x-rays, therapeutic treatment. The doctor had to perform a procedure to correct it. He had to prescribe medication to correct it. So again, that's therapeutic treatment. Further evaluation by diagnostic studies, procedures, or consultation. He had to call in a specialist pertaining to that other condition so that that specialist can look at it, because he might be a heart specialist and he might need an internal medicine physician to come in and help monitor your diabetes while he's taking care of the heart. Those conditions that could extend your stay. You might have come in for one condition, and while in, he was working on it, you came up with something else happened, and because of that other condition, it extends your stay. Well, that doesn't change your principal diagnoses, because we discussed earlier what the principal diagnosis is, but if you have this other diagnosis that required you to stay in the hospital longer, then that diagnosis needs to be captured. And then increased nursing care and or monitoring. Again, those conditions that require resources. Like I said, nursing care or additional monitoring, put you on telemetry, or cardiac monitoring, some type of monitoring. So again, those other diagnoses require clinical evaluation, one, therapeutic treatment, further evaluation, extends your length of stay, and increases your nursing care and or monitoring. If those 5 factors, any of those 5 factors come into play, those conditions are additional diagnoses that we also attach to that patient's record. Okay? So, let me give you some examples. First, a previous condition that's stated as the diagnoses. Physicians will sometimes state historical information or status post procedures that were performed on a previous admission, and they have no bearing on this current stay. So those such conditions are not coded. We don't code those. It's not fair to charge the patient for something today that was already taken care of on a previous admission. It has no bearing, no weight on today's stay. However, if a history code or a family history condition impacts this current hospital stay and it influences your treatment, then you code those conditions. For example, a patient comes in for a myocardial infarction. They have a history of a cholecystectomy that was done 2 weeks ago. Their gallbladder was removed. And a year ago, they were hospitalized for pneumonia. So in this case, the only thing you're going to code is the myocardial infarction. The fact that the cholecystectomy was done 2 weeks ago, the gallbladder was removed 2 weeks ago, it doesn't have a bearing on today's admission. The fact that they had pneumonia last year, it does not have a bearing on today's admission. So we don't code those other diagnoses, we just code the myocardial infarction. What about other diagnoses with no documentation or supported reportability? In other words, when I go to finalize reading my chart, my physician lists his diagnoses, what he thinks is wrong with the patient, or how he treated the patient during the stay, and he's listed a diagnosis that I saw no documentation for. I'm questioning where he came with that diagnosis. I didn't know the patient had that condition. So in a case like that, for example, a little boy falls from his bike and he breaks his leg. On the physical exam, the physician notes that there is a mole on the patient's leg and that the patient has an inguinal hernia. The fractured leg is reduced, so they treated the fractured leg, but nothing is done about the mole or the inguinal hernia. No additional testing was done, no further review was done of it. So in that case, the only thing I'd code is the fractured leg. The fact that the boy had a mole on his leg, okay, it's good to know, but nothing was done. The fact that he had an inguinal hernia, again, nothing was done. He listed it in his diagnoses, but nothing was done. So the only thing I would code would be the fractured leg. What about chronic conditions that are not the thrust of treatment? All right, this is where it gets a little tricky. If these conditions require or affect patient care, treatment, or management, then they should be reported. For example, hypertension, diabetes, Parkinsonism, and COPD. Those are just 4 examples. They're systemic diseases, and they should be coded because they require continuous monitoring during that stay. For example, a patient's admitted following a hip fracture. A diagnosis of Parkinson's disease is noted in the history and physical. The documentation indicates that the patient required additional care for the Parkinsonism while he was in the hospital for that hip fracture. So in that case, both the myocardial infarction or the fractured hip, which the patient came in for, and Parkinsonism should be coded because they had to still continue to monitor the Parkinsonism while the patient was in-house for that fractured hip. Okay? Again, chronic conditions that require treatment, but they weren't the thrust of the admission. They came in for this, but they also have this, and we still have to take care of this while the patient's in-house for this. So you need to also capture that diagnosis. What about conditions that are an integral part of the disease process? Integral. It's part of the disease process. Then those should not be coded unless your code book instructs you to. For example, patients admitted with nausea and vomiting, and it's due to an infectious gastroenteritis, something they ate, infected, caused some kind of disturbance in their stomach and some type of infection, and it caused the patient to have nausea and vomiting. The nausea and vomiting is a common symptom of infectious gastroenteritis. Therefore, it is not coded. It's understood that you're going to be nauseated and you're going to be vomiting if you have infectious gastroenteritis. Okay? What about those conditions that are not an integral part of the disease process? Those conditions should be coded. For example, a patient suffers a CVA at work. The patient subsequently goes into a coma, but gradually recovers to the recovers to consciousness. So the diagnoses at discharge is still CVA, because remember, that's the principal diagnosis. That's what, after study, occurred on that patient. They were brought in for a CVA, but you'd also code coma. This particular patient went into a coma. That would be an additional diagnosis, because coma is not implicit with the CVA. Everyone that has a CVA is not going to go into a coma. This particular patient did. Therefore, additional resources were used to assist the patient with the coma in addition to the CVA. So in that case, we do capture it. And then what about abnormal findings? Such as I'm reading the record, I'm looking at the lab, or oops, their lab values are off. Or x-rays, oh, the x-ray picked up this. You know, and or the path report. Whenever the body part is removed during surgery, that body part is required to go through pathology, where they're going to research it and determine, was anything really wrong with this appendix when it was removed? And if so, what? Was it appendicitis? Or was nothing wrong with that appendix and it was removed and it should not have been? Any body part that's removed required to go through pathology. So as a coder and I'm reading the chart, I'm looking for lab values, I'm looking for x-rays, I'm looking for pathology to make sure my physician is capturing everything. Okay? So when I find these abnormal findings, do I code them? Well, the answer to that is, when a physician cannot arrive at a related diagnosis but indicates that finding, if your physician says, well, on the pathology we found, oh, by the way, diverticulitis, and the physician had to prescribe medication for it, then yes, you code it. But if you find something and your physician didn't note it in his list of diagnoses, query your physician. Ask your physician, say, you know what, I found this in the x-ray or in the lab, and I noticed where you treated this, but you didn't list it in your diagnoses. Can we capture that? And if so, will you document? Would you put another paragraph or two in your documentation that says you picked up on it, you treated it, therefore it's listed in your diagnoses? And trying to be the perfect coder, when I first started off at coding, I was trying to find stuff because I wanted to make sure my physicians knew they had a good coder. I would be reading the chart and I would try to find diagnoses that my physician may have overlooked, or he may have captured but didn't fully document it, but he was treating it. And so I wanted to be that coder. And so I was trying to find stuff. And when I would find stuff, I would send a little note, a little sticky to my physician, say, you treated this. Can I capture it? Can I bring some more resources in? And so just be careful with that, because the biggest thing I would always do for some reason would be when an x-ray result would show scoliosis of the spine, where the spine started to decline. And I would write my physician, say, look, the x-ray picked up on this. And he'd write me back and say, yes, ma'am, but when you're 88 years old, you're going to have that too. That's expected. Therefore, we don't capture that. Nothing more was done. I didn't treat the patient any differently because of it. Therefore, I can't capture it. So when you see abnormal findings, just remember, okay, it flags, but let the physician make the diagnoses or check to see if services were rendered. Okay, so this describes other diagnoses that we would capture in addition to the principal diagnoses. So if you wondered, what do we code and how do we know when to code what diagnoses? Re-listen first to the previous video on UHDDS principal diagnoses, because that's where we start with our principal diagnoses. And then this video, and listen to these two videos over and over until this stuff starts to make sense. And you'll start feeling it. You'll start grasping the rhythm. I always say coding is a rhythm. You'll start grasping your rhythm to your coding. Okay? And if you have any questions after you're listening to this, feel free to email me. And if you haven't yet subscribed to my channel, feel free to subscribe so that you don't miss a video as we're doing this series. Hopefully, as we do this stuff will start to sink in. You'll start to learn coding and you'll be ready. So stay on this journey with me. See you in the next video, guys. Thanks.